I get a lot of my students who send me ECGs and, sir, we don't have tropi. I need you to tell me if this ECG is abnormal or normal purely because I need to give them the cardiac loading doses and refer them to a PCR or thrombolysis center. Indians tend to have a lot of patients who are much younger at presentation with MI. We've seen a lot of them present with inferior wall MIs presenting as gastroenteritis.
Nitrates, of course, also produce a lot of headaches and people don't like to take it. Other than nitrates, you have Myocardial, which is a very good anti-anginal therapy. It also produces headaches, but again, it's a very good anti-anginal therapy. So echo can help in making the diagnosis of infarct in doubtful cases. But I think that in an acute situation where the ST elevation is there, other than knowing the significant amount of damage to the heart, the echocardiography per se will not make the diagnosis.
Welcome to CSA Podcast. The Community Science Alliance, or CSA, is a partnership of community-based organizations, clinicians, and researchers advancing the science and practice of contextually relevant evidence-based medicine in resource-limited settings. The CSA Podcast builds on our focus in primary healthcare. I am Dr. Charuta Mandke from the CSA, and I invite you to enjoy these podcasts which cover common disease entities.
This is the CSA Podcast, presented by Social Alpha.
Hello everyone, I'm Dr. Chaitanya. I'm from the Community Science Alliance and an associate professor in medicine at Albert Einstein College of Medicine in New York. Community Science Alliance, or CSA, is a partnership of community health organizations, clinicians, and researchers advancing the science and practice of contextually relevant evidence-based medicine in resource-constrained settings. These podcasts are a series of podcasts which are built with the focus of primary healthcare. And today, we are in conversation with Dr. Chaitanya Harita. Dr. Chaitanya Harita is an assistant professor in medicine at St. John's Research Institute, Bangalore. And today, we will be discussing how to diagnose and manage acute chest syndrome or chest pain as a common presentation in the resource-constrained settings within India. Welcome, Chaitanya.
Thank you so much, Shatin. So happy to be on the podcast.
Over the last year or so, we have seen a slew of cases where young individuals and celebrities have had cardiac events, presumably coronary artery events. We are not entirely sure, there is no doubt about it that there has been a rapid rise in coronary artery disease, which correlates with a rapid rise in diabetes in Southeast Asia. So vascular diseases are in general are rising. Which brings us to the first question of the podcast: how can a physician recognize that a patient coming in with chest pain is having an acute coronary syndrome?
I think that's a critical question, Kshitij. When a patient presents either to the outpatient or the emergency department with chest pain, one of the most important things is a very detailed and good history. Not just about the characteristics of the chest pain, which we'll touch upon later, but also relevant past history, especially patients who've had a prior history of coronary artery disease, are known to have peripheral vascular disease, known to have a prior abnormal stress test. Chest pain in such patients becomes extremely critical to look into. In addition to that, of course, the classical symptoms of the chest pain that we're all taught through our medical school, the site of chest pain, its character, radiation, associated symptoms, all of that still holds good. But I think, additional history, especially of a prior abnormal stress test or a past history of coronary artery disease, becomes very, very important.
The typical chest pain, which used to present, with substernal chest pain, radiation to the left side of the arm, that doesn't hold true anymore. Over the time, the presentation has changed now. Is that true?
Very, very true. In fact, the classical, Levine sign where the patient will hold his fist over his chest, say it radiates to the inner side of the left arm, has now been found to be a very small percentage of patients with angina chest pain. In fact, pain radiating to the right arm, pain radiating to the jaw, pain radiating to both right arms or even the presence of, chest pain, which doesn't sound like angina, just a squeezing type of pain, retrosternal burning, all have been found to have presentations in patients who do have some sort of myocardial ischemia. The common differential diagnosis that we consider when we have chest pain is, either acycpeptic disease, or a musculoskeletal chest pain, or sometimes even a pleuritic chest pain. So I think looking at just the classical radiation of the left arm is no longer valid in this day and age. There are so many atypical presentations of chest pain now.
Thank you, Chaitanya. This actually reminds me of that wonderful paper by Greg Faneroff. Does this patient with chest pain have ACS? And they actually mention in the paper the probabilities, likelihood ratios of what symptom sign correlates with the likelihood of having ACS. And I, like you correctly said, it was fascinating that the highest likelihood ratio of a particular symptom to correlate with acute coronary syndrome is radiation to both arms, and not to the left arm or the right arm, which actually is relatively poor. Another very interesting thing that we found that paper mentions is one of the classic findings was improvement of chest pain with nitroglycerin, and that has been reported as suggestive of angina. If patients take sublingual nitroglycerin and the chest pain improves, that is suggestive of angina. But that actually does not have a very high positive likelihood ratio. And so like you also said, the pleuritic chest pain, which should have a very high negative likelihood ratio, because if the chest pain is pleuritic, it means it's not cardiac. That also does not hold true. So what you're suggesting is that chest pain can present in any of these fashions, and it is important to recognize that radiation to both arms might be a classic sign of ACS, along with some of the others that you mentioned. Are there any features associated with clinical exam which may point towards high risk of being high chances of this being an acute coronary syndrome?
So that's something that we also look at. So in addition to taking a very detailed history, I think systemic examination is something that we should not overlook, because the likelihood ratios of some findings in our clinical exam also point towards it. For example, patients coming in with hypotension, systolic blood pressure of less than 100 in that paper had a higher likelihood ratio. Patients with unexplained tachycardia of more than 120 sometimes is indicated that they could be undergoing underlying ischemic chest pain. Clinical examinations showing basal crackles, of course, is another thing that indicates that they're going into congestive heart failure, especially left ventricle. So in addition to the classical chest pain or the non-classical, as we've just described, I think the examination of the vital signs adds a lot of weightage to this. The other common thing that we see in our clinical practice here, especially because Indians we tend to have a lot of patients who are much younger at presentation with MI. We've seen a lot of them present with inferior wall MIs presenting as gastroenteritis. So often we see bradycardia and hypotension, assuming it's hypovolemic in nature, but actually if you do an ECG, you could see changes in the inferior wall suggestive of changes there. So it's important not to neglect clinical examination, especially blood pressure and pulse in such situations.
Thank you, Chaitanya. It's very helpful. And now that you mentioned ECG, are there specific ECG characteristics which point towards high likelihood ratios of being ACS or otherwise?
Looking at the ECG is something that, as we all know, and as we've been taught, as an art. There are some ECG findings which are specific, which we know, which are the classical ST elevation myocardial infarction, where you see, ST elevation, then you see the T wave inversions, which are commonly occurring in that particular pattern. But something I'd like to point out is that there is a preceding phase before classical ST elevation, where you get hyperacute T waves. Now, as we know, these can be seen in early repolarization. They can be seen in patients with gross LDH, and we even seen in hyperkinemia. But especially in early ischemia, they may precede the ST elevation, which is something that you should keep in mind. Which is why doing successive ECGs is very, very important in patients who you're not very sure. In addition to the classical ST elevation, in fact, ST depressions have found to have a higher likelihood ratio to indicate that this is actually an ongoing ACS. We should remember that you also have NST elevation MI, non-ST elevation MI, and unstable angina, both of which can present ST depressions. And in fact, unlike ST elevations, ST depressions even of 0.5 millimeters tends to be significant. So looking for ST depressions is also important. T-wave inversions, of course, do indicate ischemia, which need to be correlated with the patient's history, any evidence of old coronary artery disease, which I mentioned earlier. Also like to tell some of the trainees especially who are going to watch this or listen to this, that a left bundle branch block is something that should never be neglected, because new onset of left bundle branch block could indicate an acute myocardial infarction. So whenever you see a left bundle branch block, always look at a previous ECG before you label it as something the patient already has.
It makes me wonder if there are, using some of these symptoms and signs and some of the clinical presentations that we discussed, if there are risk scoring systems which have been developed and validated, which allows a provider seeing patients with chest pain which may have ACS to triage them appropriately for, say, early diagnostics or early intervention, like thrombolysis or cardiac cath.
I think that's a very, very vital question in many ways, because I think now these applications of these scoring systems are very important for doctors who are looking at patients with chest pain and an ECG, and to look at not just whether they have an ACS or not, but what are the risks that they're actually having a significant cardiac event which needs early intervention in terms of thrombolysis or a percutaneous coronary intervention. So there are various scoring systems which we have, but the two which have found to have the best outcomes in terms of, one, predicting whether acute chest pain is because of a coronary artery disease or an acute coronary syndrome or not, one. And two, also helping you decide which patients need urgent referral, which patients needs observation, and which patients can be reclassified as non-cardiac chest pain and then discharged for referral to an outpatient follow-up. These scoring systems are become very, very important. So the two most important ones are the TIMI, which is thrombolysis in myocardial infarction score, and the heart score. In terms of application, I think the heart score is easier. It's also more applicable for people who are working in the rural center. And HEART stands for H being the history, which it's highly suspicious, moderately suspicious of cardiac chest pain. E being the ECG findings, especially ST depressions, are something that's given strong weightage. A being the age, they have 3 age categories. R being whether they have risk factors, such as your classical risk factors for coronary artery disease, atherosclerosis, hypertension, diabetes. And the last is troponin, whether you can apply cardiac biomarkers. When I was looking this up, there's also a HKAR score, which I found would be quite applicable for our rural setup where there is no troponin, though troponin is the standard of care nowadays. So both scores are applicable. Obviously, HEART becomes slightly better. So when you calculate the heart score, you get a likelihood, and you can divide them into low, intermediate, and high risk. And when you compare that with TIMI, especially when you have high-risk patients, applying both scores is important, though TIMI definitely outscores heart in that condition. So once you've applied these scores, it helps you sort of follow a clinical algorithm. So if they're high risk, is no doubt refer for early thrombolysis or PCI. But if they're intermediate and low risk, then you have some time where you try to reassess the patient, probably repeat an ECG or tropi, and then reassess at the first hour, second hour, or third hour, depending on which guideline we follow. And if they remain low risk, then you can potentially discharge them as non-cardiac chest pain to come back to the outpatient for follow-up. So I think it not only helps you immediately triage, as you had mentioned earlier, but also gives you a sort of treatment plan for patients who fall under intermediate and low risk as well, either observe or ask them to come back to the outpatient for further.
Thank you, Chaitanya. The troponin journey has been absolutely fascinating over the decades, and I would like to discuss how this has impacted the approach to ACS. And before we move on to the diagnostics, which would involve troponins directly, um, in the 90s, I think our troponin assays were 1 nanogram per ml, and then over time, we from 1 nanogram per ml we went to 0.1, then 0.01, and now we are at 0.001, the high sensitivity troponins, as we call them. And the one thing that how this has changed the dynamics of ACS, which used to be ST elevation MI, non-ST elevation MI, now or unstable angina, which is now grouped under non-ST elevation acute coronary syndrome, is that a lot of these unstable anginas, they actually got reclassified as NSTEMIs as troponins got better and better and better, which really makes you wonder if unstable angina today, as of in this era of high sensitivity troponins, if it truly exists. And as a matter of fact, Eugene Braunwald, who's written the book Heart, mentioned in one of his papers in 2016, is it time for a requiem for unstable angina? Requiem is a choir performance when somebody of eminence passes away. And what he's insisting is that the troponins have just gotten so much better that a lot of these unstable anginas actually are classified as NSTEMIs. In resource constrained areas, however, unstable angina exists because we are discussing, and you just mentioned, there may be some centers where troponins are not even there. And this was one of the questions which student bodies posted to us prior to this podcast. What should our approach to diagnosis be? One, when you have troponins, and another one when you don't have troponins. So your thoughts on that, Chaitanya, especially when we have troponins?
I think this is again a very, very important thing that you brought up, especially does unstable angina exist, especially with the degree of sensitivity that we have. I think we'll discuss the troponin availability first. And if you do have trop available, again, there are your classical tropis which are done, the non-high sensitivity ones. And you do have, high sensitivity tropis available too. The difference is when you have the conventional tropis, we usually say, okay, the time to elevation is about 3 to 6 hours. So you may miss a myocardial infarction or an ACS in the first 3 to 6 hours because the tropi hasn't gone up. So they used to always say, do a baseline tropi, patient still having pain suggestive of acute coronary syndrome, repeat the tropi after 6 to 8 hours, and then take a call whether it's going up and then classify. And that's something that we all learned. But now with the high sensitivity tropi, as the recent as 2023, the European Society of Cardiology has said you have a 1 hour, 2 hour, and 3 hour, time point where you reassess. Because of the availability of HS drops, you need to do 1 and 0, 1, and then you can discharge patients at the end of 1 hour itself if they've had 2 successive drops which are undetectable. You can also do the 0-2 hour where you do it at 0 and 2, or even up to 0 and 3. That's how we've gone from a classical tropi waiting for 6 hours, patients in your emergency waiting under observation, to as little as 1 hour. So the trop journey has really added a lot. And if you look at most of the scoring systems that we use, like I mentioned, Heart as well, trop is included. In centers which don't have access, and which is, I think, something that you and I were discussing, is that it's extremely difficult to apply some of these scores, but it's also difficult to take a call for doctors. Their only way to reassess is to relook at the patient's chest pain and the progression of symptoms, and possibly repeat an ECG again at R3 and R6 and then take a call. But as we know, time is myocardial, and they can't afford to lose that, especially if there's ongoing myocardial ischemia. So even application of a point of care test, even if it's not HS trop, or a point of care prop, even at a rural center, will add so much benefit in ruling out or ruling in acute coronary syndrome. So we do know that there are a lot of conditions such as renal failure, blunt chest injury, even sepsis to some extent, which can cause falsely elevated trop. But when you have a patient with classical chest pain history, unequivocal ECG, you're not sure, if you have a point of care trop, it just adds value to your diagnostic armamentarium and allows you to make faster and definitely better decisions.
In your experience, have you how would you say is the availability of point of care troponin in the various settings that you have practiced in?
I think definitely very, very off the numbers that we actually need. St. John's, as we know, has a strong rural setup. So we have a lot of our doctors who are in rural India doing some fantastic work. Very few centers, I would put the number probably at about 15 to 20% at best, will have availability of some point of care trop. And it adds to them. But those who don't really do struggle, because then their only way of diagnosis is a repeat ECG and thereby a repeat ECG and history. So I think it's a very big challenge for them, especially if they have a ECG which is not definitive. If you have a classical NSTEMI or STEMI, it makes life much easier in many ways. But when you have an ECG which is not correlating the patient's symptoms, the lack of a trop really, really hampers patient care. I get a lot of my students who send me ECGs and, sir, we don't have trop. I need you to tell me if this ECG is abnormal or normal purely because I need to give them the cardiac loading doses and refer them to a PCR or thrombolysis center, or do I keep them here and observe? And these are critical decisions for them to make in rural India. So I think the lack of point of care trop is a big hindrance and something that we all should really look into and work towards.
It's very interesting, and that makes me go back to the thing that you had mentioned, that is HEAR in the absence of T. Has that been validated in large scale population studies, say within India itself, to determine its predictive values?
Unfortunately not. I think there is a head-to-head study of HEAR versus HERT, and obviously HERT did better than HER. I think it was 77 versus 89% in terms of sensitivity. But in our country, I think even today, even in centers without trop, I think if they can apply HEAR, it definitely adds value to your diagnostic tools. Because if you can apply the score, at least, especially if you have a person falling under high risk, referral is to a center which has PCI thrombolysis is immediate. It's the patients who fall under intermediate or low risk where you have to probably, that's when a trop really adds to your ability to make a decision. But I think still applying HEAR would be very useful in our setting.
I think it's important for us to discuss a fact which has become very obvious over the last 5-6 years or so. There has been some excellent research which has come out of the Yale Outcomes Research Center, led by Harlan Krumholz, and they have shown that ACS, acute coronary syndrome, presents atypically in women. And they have also showed that women are less likely to be offered stress testing, less likely to be offered intervention, because often their symptoms present as vague GI complaints. I would love to hear your thoughts on that.
I think that's a very, very valid point. Women are off. I think there was this paper that came out, quite a oldish paper, 2011-12, where they had shown that, as you mentioned, doing stress testing in women is comparatively less than men, one, but also underdiagnosis, of women actually being subjected to stress tests in echo and compared to men. The reason being, as you said, women do present atypically, and they may present with vague GI symptoms, sometimes just postprandial fullness with, a postprandial acid reflux. They may present with retrosternal burning rather than pain. Sometimes they present with postprandial palpitations, undefined or undescribed fatigue as well. And these are considered to be either due to a GI cause or musculoskeletal, or especially women in the perimenopausal group, sometimes attributed to perimenopausal symptoms or even fibromyalgia sometimes. But actually, when you do subject patients who have these type of symptoms to a stress test, you may discover that there is actual underlying myocardial ischemia going on. So I think in a woman who's presenting with chest pain, we need to look more carefully into not only history and examination, but also especially they have risk factors to subject them to adequate testing to reach a diagnosis fast.
To our audience and to the students who are listening to this podcast, the resources which have been cited in the development of this podcast will be placed under as presented as links. And to summarize to our audience, I think it's important to recognize certain classical signs and symptoms, but it's also important to recognize what the individual likelihood ratios are of a particular sign and symptom, and to reiterate, radiation to both arms, for example, has the highest likelihood ratio. Hypertension in an exam has the highest likelihood ratio. ST changes, ST depressions have a higher likelihood ratios. It's also important to know that pleuritic chest pain or gastric disturbances do not rule out an acute coronary event, especially in women because they present atypically. We also touched upon utilizing the scoring systems, particularly the heart score and the TIMI score. Remember, they have prognostic values, and in the absence of troponins, HEAR has prognostic value. And also, I think it's important to remember that when troponins are available, doing it at the point of presentation and repeating it in 3 hours or 6 hours, and if there is no troponin elevation, using heart score to triage as low, intermediate, or high likelihood ratio, and then decide on further care is an acceptable path forward. The next section of this podcast would discuss treatment, particularly in the era of dual antiplatelet therapy with the aspirin and the thienopyridines, the Plavix, the clopidogrels, and the ticagrelors, and where the 2B3A, the thrombolysis, and heparin fits in this treatment paradigm. I'm Kshitij Arora, Dr. Chaitanya, and I will see you again for the second part of this podcast with somebody from cardiology, and I think it'll be a fascinating discussion. Thank you all for joining. Fascinating discussion on treatment of acute coronary syndromes in resource-constrained areas in India. In our first podcast related to chest pain, we had discussed how to approach when somebody comes in with chest pain, how to realize which symptoms relate to an acute coronary syndrome. We had discussed the likelihood ratios. For example, radiation to both arms has a high likelihood ratio of this being acute coronary as opposed to just left or right. And today in this section, we will be discussing, once an acute coronary syndrome is diagnosed, how to treat it. We are very fortunate to have Dr. Jamshed with us today. He's a director of cardiac sciences at Kokilaben Hospital, Mumbai, a world authority in this field, in the field of lipid management. He has written several books, book chapters, plethora of papers to his credit, and I think it'll be a fascinating discussion. Welcome, Dr. Dalal.
Thank you, Rishad.
Dr. Dalal, I believe it was early 20th and 19th century when Willem Einthoven came up with ECG, and we started characterizing acute coronary syndrome on whether the ST's elevation goes up or goes down, and to this day we're still using it. The 12-lead ECG and what it shows, ACS now is classified as unstable angina and STEMI or STEMI. I think our audience would love to know how to approach each one of these syndromes and how to manage. Let's begin with STEMI.
As we have discussed, this session is predominantly going to deal with the management of various acute coronary syndromes in a situation where not everything is available. It's easy when you have everything available to make a protocol and say follow these protocols as has been done in USA or other Western countries. But particularly in resource-limited areas, the doctors may be handicapped in not having everything available. So let's take a very simple example of maybe a 50-year-old man who presents to the primary physician with chest pain. The primary physician's responsibility is to make a diagnosis, which may be completely a benign problem to a very severe life-threatening problem. I think the clinician's judgment of the history and physical findings are extremely important. And I think whether you have resources or not, the physical examination and history taking still remains a very vital and important aspect of treatment. So having an ECG and a troponin value immediately through a handheld device, rather than sending to a laboratory miles away and getting reports hours later or maybe even next day, I think this would solve the problem. This is one thing that we should aim for, trying to have an immediate value of troponin with a machine which is available to the primary physician. So these are simple things that you can follow. And now if we do the second part, the patient who comes with an ST elevated myocardial infarction. There, of course, treatment becomes very urgent. In my opinion, if the ST segments are elevated and the patient has typical chest pain and you made a diagnosis of STEMI, ST elevated myocardial infarction, you can do cardiac enzymes, but they do not help further in the diagnosis. They may help in prognosticating depending on the value of troponin rise, etc. But a troponin is not essential to make a further diagnosis once the ST segments are elevated. Of course, you may have a rare situation where the patient may have an acute pericarditis and the ST segments will be elevated in such a situation. But in acute pericarditis, the ST elevations are throughout the ECG. Whereas in an ST elevated myocardial infarction, it will be either in the inferior leads or in the anterior leads or lateral leads, depending on the focus of myocardial infarction. So an ST elevated throughout, suspect acute pericarditis. Must also remember that cardiac enzymes do go up in acute pericarditis as well. So that may not really help you. But I think the ECG and the clinical findings, possible pericardial rub may help you to make a diagnosis. But let's leave that aside. If you have a myocardial infarction with ST elevated infarction, you need to treat promptly. What you need to do in your limited resources area is to give the patient aspirin. Please do not give enteric-coated aspirin. Please do not give 75 milligrams of aspirin. Please keep non-enteric-coated aspirin, at least 300 or 350 milligram tablet which is available, and ask the patient to chew the tablet. You want the aspirin to get into the patient's bloodstream as fast as possible. Enteric-coated will take time. Soluble aspirin will act fast. Soluble aspirin, if put in water and dissolved and drunk or by chewed by the patient, will go directly into the mucosa through the blood, through the mouth, and give very quick action. So that's the correct way of giving aspirin to get it going into the patient as fast as possible. Then, of course, you give clopidogrel as well. You need not worry about prasugrel and ticagrelor, or if you have it, we can discuss that later, but it's not essential that these patients should be given ticagrelor or prasugrel. They may, in fact, in some patients produce bleeding problems. So if you have clopidogrel, which is easily available, lots of generic clopidogrel, fairly cheap. So give clopidogrel. Again, the dose varies, depends on the age of the patient and whether you are thrombolizing the patient or not. Elderly patients above 75, you don't give loading dose of clopidogrel. Otherwise, you give a loading dose of clopidogrel, and that may be 300 milligrams or 600 milligrams, depending on the situation. So you've done that. You've given the aspirin, you've given the clopidogrel. So you started the antiplatelet therapy, which is very, very important. Early aspirin, in fact, can halt the process of myocardial infarction or at least reduce the damage induced. So clearly giving the aspirin in a soluble form, as I mentioned, along with a loading dose of clopidogrel. And the reason why you load the patient is to get a high level so that you get peak level of clopidogrel quickly. If you give simply one tablet of 75 milligrams, it will not have adequate antiplatelet activity soon enough. Then what else can you give? You can give statins. Statins are not going to have immediate effect, but clearly a large dose of statins, that is a full dose, 40 milligrams of rosuvastatin or 80 milligrams of atorvastatin should be given immediately to the patient. What else can you give the patient? Should you give low molecular weight heparin? We'll put that aside depending on whether you can thrombolize the patient or not. So obviously an ST elevated myocardial infarction must undergo an immediate angioplasty or immediate thrombolysis. Now, in a limited resources place, I know that there is no question of immediate angioplasty within 60 or 90 minutes. So if that is possible, great, send the patient. So what I would suggest to all primary doctors is that you should know where is the nearest hospital or nursing home which can do angioplasty, and which is the nearest hospital or nursing home which can do thrombolysis. That is taking for granted that you yourself cannot thrombolize. So if you cannot thrombolize and you need to send the patient to an ICU, obviously when you thrombolize a patient, the patient will require ICU monitoring. You can't thrombolize the patient and send the patient home. So obviously monitoring facilities and ICU will be required when you thrombolize the patient. So once you know where your centers are, if you're lucky enough to be close to a patient where thrombolysis is possible, then quickly transfer the patient to that center. Before you transfer the patient, you can give low molecular weight heparin, 1 shot subcutaneously to the patient. There are regimes where you give half dose of low molecular weight heparin intravenously and the half dose subcutaneously. Let's not confuse the things too much. You're at a primary level. There's a lot of concern about managing these patients and complications. I would just keep it subcutaneous low molecular weight heparin. I think people may argue why it takes time, etc., but I think you can't do everything in a limited resources. You must do what is the practical as well. Once you decided the patient requires thrombolysis, it is your job and the patient's relative's job to make sure the patient reaches that place as early as possible. Sometimes I'm surprised patients' relatives don't respond. They often take the patient home to get the clothes, etc., and then take the patient to the hospital. No, the patient has to be rushed as fast as possible. Ambulance, of course, if available. But mostly in India, I've realized that ambulance takes too much time, even in big cities. So we don't usually wait for the ambulance. Take the nearest transport, cars, taxi, auto, whatever you have in your area that can take the patient quickly to this hospital, which you already predetermined is the one which is closest to where you are practicing. If you can phone and let them know that you're sending a patient with an acute myocardial infarction, it will be better so that they are prepared for the patient and can keep things ready. Then, of course, the patient needs to be thrombolized. And when you thrombolize the patient, you give either tenecteplase, retiplase, or streptokinase. Streptokinase has been used for generations. It is still being used in India. It's used because it is cheaper. The problem with streptokinase is that it has to be given intravenously and therefore you need an infusion, which makes it more difficult. It often produces hypotension and it produces more bleeding than tenecteplase or retiplase. Most of the big hospitals use tenecteplase. The big advantage of tenecteplase is a one-shot dose. So you just give an IV shot of tenecteplase. You don't have to worry about setting up an infusion and drips. If you have tenecteplase, fantastic. That's a great thing to do. And the importance is that maybe, as I mentioned, if you can have a handheld device for measuring troponin, if you all can be supplied with tenecteplase and some information on how to use it, then if you give tenecteplase, then that will be tremendously beneficial for the patient. Because the quicker you give the thrombolysis, the better the effect. In fact, thrombolysis given within the first hour is in fact equal to or even better at times than primary angioplasty. So very early thrombolysis is very, very effective. So if you can do it, good. Especially my worry is that if you are in a place where a thrombolytic center is very far away, say 3-4 hours drive before you can reach that area, or maybe a train drive, I don't know where you all are located. But if this is the situation, then if you could give it, it could be life-saving for the patient. Yes, occasionally patients can bleed because of thrombolysis. We need to tell the patient's relatives, but you must also remember that the chance of the patient bleeding or having serious consequences of bleeding, which is cerebral hemorrhage, are far, far, far less than him dying of the myocardial infarction. So I think that side effects of medicines should not prevent you from treating a life-threatening problem like myocardial infarction. So when you have the ST-elevated myocardial infarction, aspirin, clopidogrel, low molecular weight heparin if you can't thrombolize, or tenecteplase if you can. If you can't do anything, shift the patient to the nearest place. Inform them that the patient is coming. If you have a little difficulty in reading the ECG, I don't know how much experience all of you have. It's today so simple. Just take a picture of the ECG, WhatsApp it to your doctor. So keep a doctor who's has an ICU friendly with you, have his phone number and WhatsApp number, WhatsApp the ECG to him. I say, I got this patient, he's got this ECG, what do you think the ECG contains? It's not just in small. I get ECGs WhatsApp to me at home from my residents in the casualty all the time. WhatsApp has completely changed management. I not only get ECGs, I get echoes, I get coronary angios done and then sent to me saying, should we go ahead with angioplasty or should we not do it? So I think WhatsApp has become such an easy, cheap, free, in fact, method of transferring medical knowledge that I think that's the way you should go. So please have ECG transfer as one of the availabilities with you. So this is the ST elevated myocardial infarction, which you send to the hospital because he needs thrombolysis or primary angioplasty. Do not worry too much about primary angioplasty because that is most difficult to do. Even in big centers, it never gets done within the first 90 minutes. And we all know that pharmaco-invasive therapy, which is in thrombolysis followed by angiography and angioplasty if required, is probably one of the best forms of treatment. Because this is early reperfusion followed up with an angioplasty or angiography to take care of the problem related to the underlying blockage. So this is the best way to treat an ST elevated.
This was very, very useful. So just to summarize it for our audience here, so it seems like when patients come in with ST elevation MI, diagnosis is fairly clear. So you have buckets of treatment which you have to use together. One class is antiplatelet agents, and you had mentioned you use aspirin, or you can use dual antiplatelet therapy with Plavix. And I would like to remind my audience that this is a very contextually relevant podcast, because while Plavix is suggested by Dr. Dalal and in India, it's in the West, there is evidence suggesting now that Plavix may not be as effective, and therefore prasugrel and ticagrelor should be used, but they are not available in the practices where we have. Therefore, using some T2Y12 inhibition like Plavix is helpful with aspirin. Then you mentioned antithrombotics. You said Lovenox, which is I believe available in the centers that we had reviewed. Then you mentioned thrombolysis, a very, very critical piece to managing STEMI. You had mentioned using ECGs, transferring through WhatsApp to help identification. What does a successful thrombolysis look like? Is there a way we know that thrombolysis has been effective? For example, will the ST elevation go down by 50% or more, or any ECG findings or anything which would tell us that thrombolysis is effective? And what should we do if it is not?
Well, once the thrombolysis is effective, it's pretty easy to make out in majority of patients. The chest pain begins to get much less and usually subsides completely if reperfusion is established, number one. Secondly, the ST segments begin to go down. They may not normalize, but certainly begin to go down. And thirdly, you get reperfusion arrhythmia, so you get ventricular premature beats, which may sound worrying, but at the same time, they also suggest that there's reperfusion. But clearly, the chest pain reduction and the reduction of ST segment, whether you get a reperfusion arrhythmias, is immaterial. But these two usually suggest that the patient is responding. Now, if this does not happen, which in certain patients it may not happen, they continue to have chest pain and ST elevation, in which case there's no other option than to rush them to the nearest angioplasty center.
Is there an existing national model which takes into account the necessity of getting patients to a CAT, which can be used as an example nationally? Does such a model exist in the country?
Yes, in South India, there's a wonderful model. Dr. Mulasari, Dr. Abraham, a number of them are involved with this module. It basically involves the government as well. The importance is that you need insurance, because the problem is that you're dealing with patients who have financial problems, and therefore you need to make sure that they're supported by insurance. The advantage of this program is that the governments are involved in this via an insurance which is reasonably priced, so most people can join with this insurance. Once you have this insurance and you're logged on to the system, then if you have a chest pain, you go to the primary physician who is within that network of yours. He will take an ECG, and he will send it to the what they call as a spoke and hub. So you are the spoke, the primary physician is the spoke. So he takes the ECG and he WhatsApps the ECG to the hub. The hub makes a diagnosis that this is acute myocardial infarction. He then guides the primary physician, give the aspirin, give the clopidogrel, and the ambulance is sent over. The ambulance is also a part of the insurance program, so the patient doesn't have to pay for the ambulance. Once the ambulance reaches them, they thrombolize in the ambulance so that the primary physician doesn't have to worry about the thrombolytic path and the complications. So the ambulance will take care of the thrombolysis. The ambulance, of course, knows which are the centers close by, and they will take the patient to the ICU center which is available. If the ICU center is closed, they will take to that center while the thrombolysis is taking effect. If the thrombolysis works, very good. You don't need to do angioplasty immediately, but you need to do it the next year maybe within 24 hours, because some of these patients will re-occlude and produce reinfarction. So all patients who are thrombolized should have an angiography done to make an assessment whether they need an angioplasty or not. Surprisingly, a significant number of them, the thrombus will dissolve, the underlying plaque may not be so severe, and they may not even need angioplasty. So clearly, every patient who has thrombolysis doesn't need angioplasty. If, however, the patient is taken to a center which has got angioplasty facilities, the ambulance may decide that, okay, we can reach the center within an hour's time. We won't thrombolize the patient. We'll take the patient up for plasty. Again, very important to inform the center that you're bringing the patient so that they can be ready. It should not be that the patient comes to the center with an acuteMI and the technician of the cath lab is not available. He has to be called from home, or the doctor is not available. Once the patient reaches the hospital, usually, as in some of the Western countries, you don't even take the patient to the casualty, you take them straight to the cath lab. But it doesn't matter whether they're weak through the casualty or otherwise. But the bad part is they should not be kept in the casualty waiting for an hour or 2 hours, waiting for the cath lab to be set up.
Thank you. And one of the questions that actually has come up from our students a lot, is there any role of an echocardiogram in an acute STEMI?
In a major hospital or where facilities are available where echocardiography machine is in the in the emergency department itself, we always do an echo, because the echo tells us how much damage there is to the ventricle, whether it's a big infarct or not. And sometimes they even help in the diagnosis of infarct if the ECG is borderline. So suppose, for example, you have an ECG which is showing ST segment changes, but the echo shows that the inferior wall or the anterior wall is akinetic. Then you know that this is already an infarct and eventually the STs will go up. So echo can help in making the diagnosis of infarct in doubtful cases. But I think that in an acute situation where the ST elevation is there, other than knowing the significant amount of damage to the heart, the echocardiography per se will not make the diagnosis. It might help you to judge if there's an associated mitral regurgitation or we have a pericardial effusion or something. But in my opinion, an echo is not essential for making a diagnosis or treating the patient with an MI.
So thrombolysis is the key. You have mentioned that if available, tenecteplase or alteplase is superior to streptokinase. But if not, use streptokinase. Time is heart, time is myocardium. Therefore, don't wait and to thrombolize. Use whatever agent is available. We have certainly come a long way from oxygen and morphine and nitroglycerin and how we manage STEMIs, even in the resource poor areas now. With that, I think we should transition to non-ST elevation MI now. How different is the management of non-ST elevation MI compared to STEMI?
Well, one thing is you do not thrombolize the patient who has non-ST elevation. So clearly, if the ST is not elevated, thrombolysis is not indicated. Most of the other treatment will remain the same. So number one, you will give aspirin as you would, as I mentioned, soluble aspirin. You would give clopidogrel as you would. You would give statins as you would for STEMI. Then, of course, with unstable angina, you can use other drugs. You can give nitrates. I'm a little bit hesitant about giving nitrates in acute MI with ST elevation, especially if the blood pressure is borderline. Because when you give nitrates to somebody for the first time, often the blood pressure drops because of vasodilatation. So if you have a patient with an ST elevated MI with a borderline blood pressure, giving nitroglycerin might produce drop in blood pressure. And nitroglycerin usually doesn't have dramatic benefits in an acute myocardial infarction. It doesn't reduce MI size or anything acutely. But in an unstable angina, where usually the blood pressures are normal, unlike a STEMI, where usually the patient is tachycardic, hypotensive, in a non-STEMI, patients usually the pulse blood pressure are not that bad. So you give nitrates for relief of pain. Especially if there's tachycardia and the blood pressure is adequate, then you give beta blockers to slow down the heart rate and control the angina or the chest pain. We also use other drugs like metabolic drugs like trimetazidine, which I know are not available in USA, but trimetazidine is very popular in India, very popular in Europe, and we use trimetazidine as an anti-anginal metabolic drug. You can also use nicorandil, which is freely available all over the world, as one of the other vasodilators. So aspirin definitely, clopidogrel definitely, statins definitely. You can try nitroglycerin subcutaneous, a patch or sublingual or a spray, whichever is available with you. I think a spray or a sublingual tablet is probably the best way to give it. And then, of course, you can use beta blockers, nicorandil, trimetazidine as additional drugs. The aim here is to relieve the patient's angina. Once that is done, then the patient has to be shifted to a place where angiography can be done. So here you just skip that whole thrombolytic pathway and you treat the patient medically and then shift him to a center where angioplasty can be done. It's not that we always talk of angioplasty, but basically this patient needs an angiography. So many of these unstable patients after angiography may show that the blockage is only in a small artery. They may not need angioplasty, or they may have critical multivessel disease and they may need bypass surgery. So those decisions can only be done by angiography, and you need to shift them to a center where angiography is done. Obviously, unlike an ST elevated MI, the urgency is not so much. Once you've treated them medically and stabilized them, the angiography can take time depending on the center and the distance.
In STEMI, if the thrombolysis is successful, let's say, how much time do you have before angioplasty should be done? And in non-ST elevation MI, how much time do you have before an angioplasty could be done?
In a patient with ST elevated MI who responds well to thrombolytic therapy, angiography should be done within the next 24 hours, which basically means that when a patient comes in the middle of the night, you can wait next day morning to do the angiography. There's obviously much difference between doing an angiography and an angioplasty in the middle of the night with limited staff and limited personnel compared to doing in the morning when everything is available. So clearly, in fact, this happens all over the world now, that if you have a well-resolved thrombolytic therapy patient, you can wait till morning. But don't put it off. Don't send the patient home, or don't say I will wait for 2-3 days for the patient to stabilize before doing angiography. It's a very common way of treating in India. You don't need to wait for the patient to stabilize because many of these patients won't stabilize, they will reinfarct. In a patient with unstable angina, if the pain settles down, then you can wait till next day morning to do the angiography. If the patient presents you during daytime hours and you have facility of angiography, please do it immediately. If the patient with non-ST elevated MI continues to have pain, then do angiography immediately.
Over the last, probably the last decade or so, it seems like the acute coronary syndromes have been reclassified in a way as unstable angina, STEMI and NSTEMI being type 1 MI, and an entity called demand ischemia being type 2 MI. Is there a way to distinguish between the two? Because I'm sure the management differs a whole lot in how you manage type 1 MI syndrome and type 2 MI syndrome.
My honest answer is that for primary physicians, you shouldn't get too confused about it. The type 2 MI is the one which you get with, say, tachycardia or emotion, what you call as all sorts of various reasons why that might happen. And I think that that's a different entity. It's not such a common entity. You can have it following where, somebody has an electric shock and he can go into myocardial infarction. Somebody can have an emotional shock and go into an infarction. So those are different aspects of the, Takasovo's disease, for example, where the arteries are normal and the left ventricle gets damaged. But I think for all practical purposes, when a patient has no other grave, other consequences or sequences and presents with chest pain, treat it as a regular myocardial. The other ones will be too obvious.
I believe the next question that I have in my mind is, if an acute coronary syndrome presents with unstable hemodynamics, what should the physician in that setting do then?
Well, unstable hemodynamics, so I would suggest, would have three components. One is the patient would be very tachycardic, but that tachycardia is a response to the hemodynamic instability. His blood pressure may be low, which is a big problem, and his oxygen saturation may be low. So if the patient is going into, say, pulmonary edema and oxygen saturation is falling, the crepitations in the chest and patient is breathless, then of course the treatment is IV diuretics to clear the lungs and maybe nitroglycerin if the blood pressure is not low to help clear the lungs as well. So patient presenting with breathlessness, low oxygen saturation and crepitations in the lungs, diuretic therapy will be required in addition to what we have already mentioned treatment-wise. If the patient is hypotensive, then that's of course another very big problem because a hypotensive patient is going to go into shock unless you correct the hypotension. Important thing to improve the hypertension is to try and get the patient reperfused. Therefore, your aspirin, clopidogrel, and most probably if you can give thrombolysis to the patient, that would help the patient in terms of relief of the thrombus and therefore improvement in hemodynamics. If, however, you can't do that and the patient remains hypotensive, you could give IV fluids to the patient, just normal saline to the patient, IV, if the patient is not in pulmonary edema or not in, evidence of left ventricular failure. So first you would give IV fluids. If you have, of course, dopamine, then of course you can start a dopamine infusion. If you don't have dopamine, then it's a bit of a problem. You can give a bit of noradrenaline, again, very small doses, but then you're talking of a very critical ill patient and you're trying to do critical treatment. It all depends on how you can manage these patients. So when a patient presents to you with STEMI and shock or STEMI and hypotension and pulmonary edema, it's patient's really in bad trouble. But still, I would suggest that you try and stabilize the patient rather than put him in a taxi or an auto to send him off because then he's going to die on the way. So try and give him some diuretics. If you have dopamine or some sort of an inotropic agent, a small dose of NORAD or whatever you can give to the patient during transport so that the patient can reach some ICU setting where then better treatment can be done. IIBP and of course all those things are not going to be possible unless you have a cath lab situation. Then, of course, you're talking of a cardiologist taking over, putting an IIBP, doing angiography and all the procedures. So clearly, once you need a situation like an IIBP, it'll have to be a major center with full cath lab facilities, surgical team, etc.
Moving on to this entity, which is somewhat debatable now, at least in the West. Eugene Braunwald in 2016 wrote a paper and he said, is it time for a requiem for unstable angina, which requiem is a choir performance when somebody of eminence dies. Essentially, he's calling to retire the word unstable angina because what he's suggesting is that troponins have gotten so much better that a lot of these unstable anginas in the 1990s, from the data that's from the 1990s, is actually reclassified as NSTEMIs now. Wherefore, unstable angina as an entity is quite rare. I believe with the troponin assays available in our resource poor areas, which is 1 nanogram per ml, unstable valid entity. Would you agree? And if yes, is there any nuanced difference between how you manage unstable angina versus NSTEMI, or is it exactly the same?
Well, if you want to look at unstable versus non-STEMI, then basically if you have myocardial necrosis, then you become a non-STEMI. If you don't have myocardial necrosis, you become unstable angina. Now, how do you diagnose myocardial necrosis? The best way, of course, is enzymes. So if you do CPK, which is probably the less sensitive of the two, then you might miss a necrosis and therefore you might call the patient unstable angina. But as you move from CPK to MBCPK, from MBCPK to troponin, from troponin to HS troponin, which becomes more and more sensitive, then many of these so-called unstable angina patients will now slowly move towards myocardial necrosis and therefore non-STEMI. I don't think it really makes much difference in treatment for two reasons. One is that both of them do not need thrombolysis. The non-STEMI patient probably becomes a little more urgent in treatment. But again, an unstable angina can quickly shift to unstable, to non-STEMI or even to ST elevated MI. So therefore, unstable angina also needs to be treated aggressively. The treatment remains the same as non-STEMI, which is basically aspirin, clopidogrel, statin, beta blocker, nitrates. And again, shift to the cath lab for angiographic evaluation. So I don't think that there's a great difference between the two. Whenever the trop is positive, you say it becomes a non-STEMI, and enzymes are negative, you say it is unstable angina. But I think it's a very fine line between the two. And again, you must remember that one can shift to the other quickly, and unstable can become acute MI as well.
Absolutely, very important point to remember. Let's shift our focus to something which has become very interesting in the area of interventional cardiology, and that's chronic stable angina. The old adage in this field has always been that if you see an obstruction, give the widest possible lumen by putting a stent, and therefore you reduce outcomes down the road. But it seems like that adage has come into question in chronic, not STEMI and STEMI unstable angina. This is not an acute coronary syndrome. This is stable angina, which and Dr. Dalal would discuss. And then the question here is: does angioplasty have any value in stable angina in the modern medical therapy era?
So first of all, let's understand what is stable angina. Stable angina is a patient who comes to you with a very fixed type of a chest pain. That means he gets chest pain when he walks. When he doesn't walk, he doesn't get chest pain. That's mostly the typical finding of stable angina. But you must remember that when the patient has chest pain for the first time, he can't be called stable. So when a person presents to you for the chest pain first time, it is always unstable. If a patient has stable angina, that means he has angina whenever he walks, but otherwise is well. But then one day he gets up at night and has pain at rest, or during the daytime he has pain as rest. That stable angina has now become unstable. So stable angina can quickly change into unstable angina. But however, let's look at a patient who has got no other history except stable angina. On severe exertion, he gets pain. Otherwise, he's fine. He has got no hemodynamic problems. In such a situation, there are n number of trials which are now shown that the best way to treat this patient is by medical treatment. And we have excellent medical treatment now. These patients should be on aspirin. Some of them should be on dual antiplatelet therapy. There are now recent studies to suggest that if you're going to use a single antiplatelet therapy, that clopidogrel may in fact be better than aspirin. I don't want to go into details of that, but there is a lot of coming evidence that clopidogrel is more beneficial for these patients than aspirin. So if you had to use a single antiplatelet, you could choose between aspirin or clopidogrel. Then, of course, these patients need to be on statins. And very important, you need to keep their LDL as low as possible. So they should be on a good dose of statins, plus acuteMI, or on statins, or bempedoic acid in case there's statin intolerance, or even now availability of injectable lipid-lowering drugs. So reducing LDL is very, very important for these patients with stable angina. Then, of course, you need to reduce their symptoms. The commonest drug used is beta blockers, any type of beta blocker. Reduce the heart rate to around 60. Nitrates, you can use more of an acute. I don't like using nitrates on a regular basis for two reasons. Because one, it's more effective when you give it at the time of chest pain or pre-exercise to prevent chest pain during exercise. And chronic use of nitrate also produces nitrate tolerance, and the effect of nitrate goes away. Nitrates, of course, also produce a lot of headaches, and people don't like to take it. Other than nitrates, you have Myocardial, which is a very good anti-anginal therapy. It also produces headaches, but again, it's a very good anti-anginal therapy. It acts both on microvascular angina and large vessel angina, and therefore is a very useful drug. You can use anti-metabolic drugs like trimetazidine, which act on cellular level and on microvascular level. So you have multiple drugs available: antiplatelets, statins, beta blockers must. A patient cannot tolerate or has asthma, you can use ivabradine to slow down the heart rate. Nitrate, Myocardial, ranolazine is available now, which is also partly metabolic and partly through the potassium-sodium channels. So you have Myocardial, trimetazidine, ranolazine, and nitrates as your drug therapy. In majority of patients, angina will be prevented or stopped completely with this therapy. If the patient persists in having angina, in spite of the therapy, then of course he will require an angiography and angioplasty. We all know that unlike an acute situation, please remember that when you have an ACS, unstable angina or STEMI, angioplasty is life-saving and clearly indicated. When we talk of this, as I'm mentioning, this is for stable patients who do not have any angina at rest or any ECG elevation or ST depression. They can be treated medically. In this group of patients, putting a stent will help reduce the angina. So suppose the patient is on 5 anti-anginal drugs and he says, I'm fed up of taking the drugs. And if he has an angioplasty done, he can get relief of the angina and may not need to take all these drugs. So he can just then be on an antiplatelet and statin, which are what we call disease-modifying drugs, and stop all the drugs which are only anti-anginal and not disease-modifying like nitrates, ranolazine, etc. So if you do angioplasty, definitely you will get relief. There are a couple of very interesting trials called the Orbiter trials, one in which they gave medical therapy and one in which they gave medical therapy and did angioplasty, and angioplasty didn't do any good in terms of prevention of infarction or prolonging life. Then they did a second Orbiter trial where they gave no medicines to both the groups. One had angioplasty, and they found that the angioplasty itself was very useful in reducing angina. So if you have too much angina, if you don't want to take too many medicines, and if you have angina in spite of medicines, then angioplasty is very useful. But if you have stable angina and your pain has completely disappeared, in which case angioplasty may not be beneficial, except in certain circumstances. I must make sure that you understand that there are certain circumstances in which even in the patient who's stable, you might want to do an angioplasty. That is those who got critical left main lesion or a critical left main LAD lesion, or a patient who has got a poor left ventricular function and multivessel coronary artery disease. Those are the patients where intervention is beneficial in terms of prolonging life. So severe left main lesion, critical 3-vessel disease with poor left ventricular function. Now, whether angioplasty is better or bypass is better, we won't go into that because that's a whole new subject by itself. But let's say that intervention is better in this group of patients. But if the patient has, say, a single LAD or RCA lesion, then angioplasty is not necessary if they do not have angina while on medical treatment.
This has been very, very informative, Dr. Dalal. I think one last question for you is once patients with acute coronary syndrome are treated, what should be the criteria for discharge, and what should post-discharge care look like? What medicines should they be on, and what does post-discharge monitoring look like? When should they get an echo, if at all, and how should their lipids be managed once they are discharged from the acute management?
Most acute patients nowadays will be discharged within 48 hours, maybe a couple of days more. But any acute MI also with an angioplasty comes in within 48 hours they're discharged. So long, prolonged hospital stays are not required. Because basically you converted the acute myocardial infarction into normal coronary artery. So therefore you normalize them. If the LV is not damaged, that's why I feel that everybody who's had an angioplasty done should have an echo done to see for LV function, because it's very important. If the LV function is different, then the whole treatment changes, and that would be a whole session by itself, how to treat LV dysfunction, heart failure. That's a completely different thing. But a poor LV function requires a whole host of treatment by itself. So I think an echo is extremely important to differentiate a poor LV from which you can't do clinically. You cannot look at the patient and say his ejection fraction is 40%, 50%, 60%. So a patient can have an ejection fraction of 30% and be clinically fit and stable, but he still requires treatment for that low ejection fraction. When the patient goes home, you have to make sure that the heart rate is controlled. The blood pressure is controlled. Very important, make sure the blood pressure is around 120, 130 systolic, 140, 150 systolic is not acceptable. If the patient has CKD, diabetes, etc., even more stringent control of blood pressure is required, which we don't do but is important. Lipids need to be controlled. LDLs of 60, 70, 80, 100 are not acceptable in a patient with post-ACS. They must be kept below 45. In fact, more and more guidelines suggest that in patients with severe problems, that is those who have diabetes, multivessel disease, multiple plasties or bypass in the past, angioplasty or whatever it is, combination of treatment, or those who got polyvascular disease, that means heart problems plus peripheral vascular disease, or a past stroke and now a myocardial infarction, these are called as very high-risk patients. Their LDLs need to be kept even below 35. So you need to combine high-dose statins with ezetimibe. There's also some study now in India which combines ezetimibe with bempedoic acid with statin, producing very low LDL levels. Or now you have got Repatha and inclisiran, which are injectable PCSK9 inhibitors. They're expensive, and again, the lipid management is again a whole new subject by itself. But clearly, blood pressure control, heart rate control, diabetic control, LDL control is very important. Then the patient must be spoken about exercise, diet, and if possible, a rehabilitation program can be set up for the patient, which significantly improves their morbidity and mortality. In fact, rehabilitation can reduce your mortality as well, not just the morbidity. So they should be put to a rehabilitation program. All patients who had an infarct, who got damaged ventricles, must be reminded that they must take vaccination. The patient who's recovering from an infarct, if he gets influenza or pneumonia, he may die, especially the elderly. So make sure that all of them undergo vaccination appropriately. So we usually have what we call as a pre-discharge checklist. So you have to make a checklist. Is he on antiplatelets? Is he on lipid-lowering drugs? What is the LDL value? What is the blood pressure? What is the sugar control? And this must be charted out. Rehabilitation, as we mentioned, vaccination, as we mentioned. So if you have this chart in front of you, when the patient comes to you, not when the patient comes to you, when the patient is discharged, look at the chart, make sure everything is entered. If, for example, something is not done, you must write down there why it is not done. I did not start beta blockers because the heart rate was 50. Now, patient comes to the OPD, the heart rate is 80 now. So, must remember, you didn't start beta blockers because at that time the heart rate was 50, but now it's 80. Remember, and start beta blockers. Make sure the patient can join the rehab program. If they can't, then at least train them how to do exercise, etc. Should also tell them about sexual activity, etc., and other things that patients need to know, which should not disrupt their life too much. So, I think there's a lot that can be done. Of course, it takes time and effort, which many doctors don't have.
Thank you so much, Dr. Lal. To our audience, this has been a wonderful session. I hope all of us have learned a lot on how to manage acute coronary syndrome, especially given the resource constraints in rural India. And we will bring back Dr. Bilal for probably another discussion on lipid management and heart failure. So please look out for the next series of our podcast. Thank you for joining CSA Podcasts. Bye.
This is the CSA podcast presented by Social Alpha.